All right, welcome everyone. We're going to begin in just a few seconds here. We just want to give a couple more seconds for people to get set up. All right, so I think we'll get going now. So welcome everybody to the Leukemia and Lymphoma Society of Canada's webcast, advocating for yourself or your loved one. In today's presentation, Ryan Clarke, Senior Vice President, Advocacy and PR at CRG-Eversana Canada Inc. will speak about the importance of self-advocacy and will share tips on how to be an effective advocate when working with your medical team. So to begin, my name is Charlotte Hall-Coates, and I'm the Community Services Lead for the Atlantic region with the Leukemia and Lymphoma Society of Canada. I will be your moderator for today's online event. Since there are many of you, we invite you to type your questions and comments into the Q&A box on your Zoom webinar panel throughout the presentation. An LSC staff member will monitor your questions, and I will read some of your questions out loud at the end of the presentation during our question and answer period. Due to the large number of participants and our limited time, we may not get to all of your questions. Also, please note that our speaker cannot answer any specific questions about a person's health status or history. Case-specific questions will not be read aloud during the question and answer period. If we do not get to your question during our live presentation, Community Services Lead will connect with you after the webcast. Today's presentation will be recorded, therefore you can watch it again on our website. Next slide, please. If you have any questions or cannot find what you're looking for, you can always talk to one of the community services leads in your area and receive personalized assistance in finding answers to your questions or ways to address your concerns. The community services leads are here to help. Reach out to us by calling toll-free 1-833-222-4884. Next slide, please. We also invite you to visit our new website, bloodcancers.ca. Our goal is to better serve the community and offer an improved experience. On our website, find all our past webcast recordings and our podcast channel, information sheets, and practical tools to help you navigate your blood cancer experience. The website was designed with you in mind to ensure easy and personalized navigation no matter your current situation. Visit bloodcancers.ca to learn more. Next slide. Our First Connection peer support program is a support service that matches people affected by blood cancer, caregivers and their families with trained volunteers who have been touched firsthand by blood cancer and shared similar experiences. Whenever possible, participants and volunteers are matched based on diagnosis, treatment, or the issue that is most concerning to them. Contact the community services lead in your region to learn more. Next slide. To introduce today's speaker, Ryan Clarke. Ryan is Senior Vice President, Advocacy and PR at CRG-Eversana Canada Inc. A resident of Burlington, Ontario, he was educated at McMaster University in Hamilton, Ontario, where he received both an honors BA and a master's degree in political science. He then went on to study law at Western University. In 2003, Ryan founded Advocacy Solutions, a one-stop shop that helps synthesize advocacy campaigns, amplify campaign messaging, and engage and influence key decision makers. The business is now part of CRG-Eversana Canada Inc. So before I pass it off to Ryan, we did want to share 3 short blood cancer survivor videos. Ryan will be using their experiences to anchor his presentation. The first video you will see is from Paula from Ontario. We will then move to the second video from Peter from British Columbia. And the final video is from Roxanne in Alberta.
Hi, my name is Paula, and I live in Ottawa, Ontario. It's a pleasure for me to speak with you today about patient self-advocacy. I learned that I had cancer back in fall 2020 because I lost my ability to walk on my own. When I went to hospital, I had learned that I had a broken back. And through an MRI, I learned that the reason for the break was because a tumor had broken my spine at T7. In the coming days and weeks, I learned that I had stage 4 aggressive diffuse large B-cell lymphoma. This experience for me personally required a lot of medical support. Not only did I have surgery by an orthopedic surgeon, but also because I had some damage to my spinal cord, I also needed a team of physiotherapists, occupational health and safety therapists, and of course, my oncology team, which consisted of my oncologist, my oncology nurse, and others that would support through testing and blood work and those pieces. So I guess what I would say is when you have to, mobilize a lot of your medical supports, it really is personal and it's specific to the needs you have related to your blood cancer diagnosis. Many of us experience different symptoms or different, challenges with our health, depending on the type of cancer that we have, depending on how far along it is, whether or not we needed surgery or other treatment. And we really need to triage, our symptoms based on what we're experiencing at the time. I do know, in my experience at least, multiple things happen at once in some cases, and it takes some careful consideration in terms of what outreach you need at what particular times to support your wellness. What I tried to do is establish a really strong relationship with my oncology team and specifically my nurse, because the oncologists are very busy. They have a lot of patients and a lot of patients with very significant needs. And I found by calling the office and connecting with the nurse, she was often able to really help me. She understood my file, she understood what needs I had and the complexities in my current living situation. So that was one way in which I was able to really get support from that team. The other people who I think you really need to connect with and form a strong relationship with are the office administrators. And I know at first that might sound a bit funny and you're unsure of what that means, but I think we sometimes underestimate how powerful they are, how much they know about us, how they're able to support and triage our needs in connecting with our teams. So for me, whether that was my orthopedic surgeon, whether that was my oncologist, or others who could help support me during this time, I always made sure to connect with them, to be very gracious and show my gratitude for the work they do. They are a member also of our team, and even though we don't think about it like that sometimes, they're often the key to getting us the support and service we need quickly. I think another piece that is important is trying to use whatever resources you have that might not be those human resources. So the Leukemia Lymphoma Society has a ton of great information. You can connect with many supports in this program. There are other programs at your hospitals or through your clinics that also may be helpful. There's support groups, and there's others that you can connect with, for example, through the First Connections program through LLS. And those people can also help to guide you and give you some support and answer some questions. And I think that's critical because when we're in the middle of our cancer diagnosis and all of the experiences related to that, everything feels urgent. Everything feels like it's having a profound impact on your life, which it is. But when you think about the medical system and the spaces and places people are in that field, and certainly through a pandemic and following through on some of the pressures in our system, it's really important to remember that even if we feel really crappy, that there may be people who are in more urgent need of care. And so trying to resolve the pieces you can on your own is really important. And that way, when you need to reach out for help, when things are really not going well, or you need that medical assistance, the team takes notice because they are aware that maybe you're not calling every day 3 times a day, but when you call, it's when you really need that additional support from your team. I guess the last thing I would say is just a message of gratitude. And going through this experience is life-changing. It's hard to articulate the words that really encompass the experience of patients with blood cancer. But I really want to just leave you with centering on gratitude. And I know that it seems counterintuitive to be really thankful through this experience, but if you are somewhat similar to me, you're going to find some really incredible people on this journey who just kind of come out and step up for you and who are there for you and really make this experience manageable. Not all experiences will be like that, but you will find some true gems in this process. And just remember to be really grateful to those people, because them providing us with their energy and care and love is what will get us through this. So thank you, good luck, and take care.
Hi, my name is Peter Nadler. I have CLL. I was diagnosed in 2008. When I was first diagnosed, I felt sort of patronized in the sense that doctors, when they've, even at the beginning, didn't really want to diagnose it, kept wanting to repeat tests and assure me that nothing was really wrong. And eventually, through my being proactive, the diagnosis was confirmed. And then subsequent to that, I started doing quite a bit of research on my own, because I'm have the kind of personality that likes to know things and understand things. And one of the first things that I discovered was a FISH test was something that was recommended. My doctor, my specialist, once again, didn't really think it was important and only did it at my insistence. And luckily, it was done, because what was discovered was that because of 2 genetic mutations, it was predicted that the disease was going to be more aggressive and likely to be resistant to chemotherapy. Unfortunately, at the time of treatment, which was about 10 years later, I was in fact resistant to chemo. And at the time, frontline treatment was still chemo, as opposed to oral therapies that are much more common today, such as BTK inhibitors like ibrutinib, acalabrutinib, etc. Having done all this research at the time, I was prepared to move to the next stage, which was to insist on an oral treatment rather than repeating chemo. My own treating hematologist was away on sabbatical for about a year, and I was relegated to someone who wasn't really that familiar with me, hadn't followed me. And that particular specialist strongly recommended repeating chemotherapy and substituting one of the drugs, which was fludarabine, for another alkaloid agent, such as bendamustine with rituximab. I actually insisted on that not happening. And as a result of a campaign with my doctors and the team of hematologists at BC Cancer, they agreed to not continue, or not repeat rather, chemotherapy, but move on to ibrutinib, which was still relatively new in British Columbia at the time. and was really only available on a compassionate basis. So I switched to ibrutinib, and things were going quite well, except for the fact that I developed significant side effects, such as elevated blood pressure, requiring treatment, and also significant dry mouth, which was very uncomfortable. Again, because I did my own research and advocated on my own behalf for switching to a different drug, such as acalabrutinib, I was successful. I'm currently still on acalabrutinib on a half dose to try and reduce dry mouth, which is also an unfortunate side effect of the drug. However, my hypertension or high blood pressure completely disappeared and doing quite well on acalabrutinib. So what I learned is that you need to be well informed. You need to not be reliant on the doctors, and you need to be in a position to be at least close to being on the same footing as they are in order to understand what it is that is being proposed so that you can advocate for yourself. So I hope it's helpful, and I hope everybody, wish everybody well with their own journey on their own treatment and their own illness. Thanks.
Hi, I'm Roxanne, and I live in Wainwright, Alberta, a small town 2 hours east of Edmonton. I was diagnosed March 1st of 2018 after a month of severe illness with aggressive stage 4 diffuse large B-cell lymphoma, bone marrow liver spleen subtype, complicated with hemophagocytosis. A very long diagnosis for what essentially means an extremely rare form of non-Hodgkin's lymphoma. I'm a typical type A personality with strong leadership skills. I've owned my own businesses my entire working life. I'm direct and fair, but I do expect progress and results. And I was super frustrated with the lack of information I was receiving once I was admitted to hospital prior to my diagnosis. The hematology resident assigned to my case actually seemed more disappointed that he wouldn't be able to cut into me to biopsy anything than he was in providing me hope. Hope, probably the most critically important character trait for survivorship, an optimistic character trait, and not really in my general pessimistic nature. With a background in healthcare, I know how busy hospitals can be, and I understand how easy it is for mistakes to happen. They are truly accidents, and they emphasize the need for us to track and monitor our own care. One day, a nurse was reviewing the medication she was giving me. There was a new name on the list, and I asked about it. Just recognizing the names of the medications you are on and taking a moment to ask can be so important. She went back to my chart and indeed confirmed that she had accidentally taken the medication from the compartment next to the one that I should have been receiving. The mistake may have made no difference to any short or long-term outcome, but it stresses the importance that we all have a role to play in our care. Our system is often understaffed, and we are all human after all. On the day of my diagnosis, I was transferred from the University of Alberta Hospital to the Cross Cancer Institute, where I met my oncologist and ward staff. Everyone was very nice, and I was relieved to finally have a diagnosis. The entirety, however, of my diagnosis and odds of survival were not shared with me, but it was made perfectly clear that without treatment, there would be no future. On the day my oncologist presented the chemotherapy protocol, a standard cocktail for diffuse large B-cell lymphoma, he was very clear that he didn't know how well it would work given the subtype. I was numb and quiet, very much unlike me. And my husband simply asked, "So shouldn't we try something different?" A very out-of-the-box confrontation for him. He knew someone had to speak up if I wasn't. Thankfully, my oncologist thought for a moment and agreed that he would try adding an additional medication to the protocol. It takes a team effort. I'm extremely fortunate to still be here today, and I credit a good part of that to the local emergency room doctor I saw on my first visit. He did not dismiss me with the flu or assume I was suffering from stress. He took the time and ordered tests. And when those tests didn't point to a diagnosis, we persisted. He ordered more tests, kept digging, in a desire for a diagnosis and to push forward. I believe the essential critical factor as to why I'm still here. A very rare cancer is hard to diagnose and hard to treat. It has limited studies and few case reports. And in my case, as I discovered months after my treatment concluded, had a maximum life expectancy of 6 weeks after diagnosis. I truly believe that pushing for diagnosis is the key. It involves patient advocacy and finding the right doctor. These are real challenges in our current healthcare system, but advocating and having a caregiver by your side to advocate for you when you're just too sick or tired or just can't even think of the words to do it yourself is absolutely critical. I normally spoke up, and thankfully my husband of 28 years at the time knew me well enough to recognize that if I wasn't speaking, he had to. Speaking up, asking questions, keeping track. These are so important, and so is having hope.
All right, and over to you, Ryan.
Thank you, Charlotte, and welcome everybody. I appreciate you taking the time to be with us. So let's go to the overview slide. I'm going to go off camera while I'm speaking to you, but I'll come back on after after I finish the presentation. So here's an overview of what we'll be covering today, with the presentation divided into 2 primary sections that you can see there: the foundation of advocacy, and then developing a personal advocacy plan. So let's start with the basics. We go to the next slide, and that is, what is advocacy? Well, it's verbal support or argument for a cause or a policy. That's a dictionary definition that I'm not too fond of. So I've come up with another definition that I think is a little bit easier to sort of understand. It's telling your story to someone, and that someone is the what we call the target, the person who you're advocating to, the person who has what you need, through various means with the express purpose of compelling them to do, or in some cases, not to do something. It is a process that almost always takes time to realize tangible results, depending on the size and scope of the issue. And it's grounded in sound, reasonable thought or argument. There is no one way to do it. It's very personal to your own style or your own comfort level, and it's your choice as to how much you do depending on the circumstances. And finally, advocacy is about empowerment. It's exerting some form of control and initiating some form of action around an issue that matters to you. So on the next slide, we ask the question, why is advocacy important? Well, in addition to what I have on the slide here, all you really need to remember is because the squeaky wheel gets the grease. That's life. That's just how things work in our healthcare system, in politics, government, any institutional setting you may have found yourself, any systemic circumstance, the squeaky wheel always gets the grease. In addition to some of the points on the slide, it's also important because if not you, then who? Well, perhaps a loved one or a caregiver, absolutely. But in healthcare, or in our healthcare system, unlike our legal system, there's no framework for representation. You have to make these arrangements yourself. On the next slide, different kinds of advocacy. This is the slide that all of you as patients or caregivers should be able to identify with. For people new to the world of advocacy, it's almost always personal need that will compel you to take action. You're not looking to change the world necessarily, you just want to help yourself or a loved one. But it's out of this personal need that some people start to realize that they have an opportunity to bring about larger public policy change by advocating for broadly based issues. And I describe those people as having graduated. They've graduated from seeing the challenge that they face or the circumstances that they're in, which is very personal in healthcare, tends to be, into something bigger. This whole idea that, well, if I'm having a challenge, then other people must be having a challenge. And what if we could solve the bigger issue to help not just myself and my family, but help others as well? And so it's the ability to see beyond just your personal circumstances to something bigger. Most people don't graduate in their thinking, and that's fine. That's not the issue here. What I want to leave you with, though, on this slide is that for those people who do think beyond themselves, I've had the privilege of working with people who can make tremendous change, tremendous health policy change, drug policy change, and even broader public policy change when they've chosen to see the world, as I said, beyond themselves. Next slide. Advocating for yourself or a loved one is built on two foundational elements: relationships and personal stories. I mentioned a moment ago that it typically takes time to realize tangible results through advocacy. And that's because relationships are so important to the process, and it takes time to build good, solid relationships with people of influence. Now, I know it might sound odd to suggest that in the context of healthcare, where you may be coming in contact with dozens of people every year who are connected to your care, that you should be expected to try to build a relationship with each and every one of them. But the truth is, you should. After all, a relationship is defined as, and I quote here, the way in which two people are connected, close quote. It doesn't matter for how long or at what level. If someone has something you need and you want to advocate to them to get that thing, I'm simply suggesting that your likelihood of success is much greater if you have taken some time to build a relationship with them. Even just a smile, a handshake, a kind word, or even being gracious, as Paula noted, something to build a connection. And you may recall that Paula also talked about building a strong relationship with your oncology team, another excellent piece of advice. So turning now to the next slide, what is a personal story in the context of advocacy? Well, it's a summary in whole or in part, as it says in that first sub-bullet there, of what has happened to you as it relates to the issue at hand. It's also your perspective on the issue based on your experience, feelings, and attitudes. In a face-to-face meeting, virtually or in person, it doesn't matter, or in written communication with a decision maker, your personal story is what makes your issue come to life. It's critical to successful advocacy. It makes your issue real for the decision maker or provider and establishes a point of connection between the two of you, thereby enhancing your relationship. If properly developed and delivered, your personal story should fuel the logic of your one ask, which we'll talk about soon. And it should be emotional, but emotional doesn't mean sad. It's helping to motivate and guide the decision maker or provider to what you need them to do, covering a range of emotions that you may have felt as you've been on your journey. And remember, the patient has a personal story to tell, and the caregiver has a personal story to tell. They are not the same. Particularly for a caregiver, you must communicate how you are dealing with the situation, how you feel, and not just channel how the patient views the circumstances. People need to hear how you, as a caregiver, are viewing the circumstances on a personal level. So carrying on with the personal story on the next slide, you'll see the four elements, essential elements, that we feel should be included in the context of all personal stories that are written for the purposes of advocacy. I'll briefly take a look at each in more detail, but before I do, you might be thinking, why would I do this if I'm going to see my family doctor or oncologist or nurse navigator? Well, because the truth is that it's a very effective way when you first meet somebody that you're going to be dealing with to do a number of things. One, get their attention. Two, focus on what they need to know, thereby not wasting your time or theirs. Number three, have them remember you and know what's important to you. And finally, explore the opportunity that they, as a healthcare professional, might be willing to be as an advocate on your behalf. Are they willing to potentially advocate on your behalf? You need to find that out. That's all part and parcel of why we do this work. So, moving to the next slide, and number one, basic personal details. When you're crafting your personal story, the objective of this first section, the beginning of any personal story, is typically to establish a picture of who you are and to convey to the decision maker or the provider, essentially, I'm like you. I go to work, I have a family, I'm raising my kids, I have grandchildren, whatever it may be. You're establishing a baseline of who you are in relationship to some extent, the person that you are advocating to. Next slide. This is the point in the story that you transition from setting the stage to the circumstances that have brought you here today. And your diagnosis or an issue with your health is typically that point. That's typically where you transition from your background to why you're here to talk about this or what you're trying to convey in your personal story. It is also the first opportunity in most personal stories to start to open up about your feelings, which is critical to enable you to connect with, again, a decision maker or a provider, whoever it is that you're advocating to. Next slide. You need to transition from the fact of your diagnosis to the issue at hand, where you need to talk to the challenges you've had as it relates, again, to the issue at hand. So, for example, if the issue you want to talk to this person about, this provider, for example, is access to medications, don't focus on the prolonged time to diagnosis. You can mention all of the challenges that you may have faced, including a prolonged time to diagnosis. But you need to focus on the one thing that is linked. You need to focus primarily, on the one thing that is linked to the issue that you're there to resolve. In other words, your personal story really needs to highlight, broadly speaking, the issue that you're there to talk about or advocate for. And the final slide, as it relates to personal stories, is your ask. What action you need the decision maker or provider to take as a result of what you've just shared with them. Before we conclude this first section, and while we're talking about action, I just want to go off on a little tangent here about one of the most common questions I get around personal health care and interacting with clinicians, physicians, and others in the healthcare system. It has to do with the right to a referral versus the right to a second opinion. The right to a referral versus the right to a second opinion. With any healthcare provider, you are entitled to seek a second opinion. Now, note the word there, seek a second opinion. In fact, in the Ontario College of Physicians and Surgeons, on their website, this is the body that regulates physicians in the province. Every province has a similar college, a regulatory body. It says on their website, this is a quote, "You, patients, have a right to seek out a second opinion," close quote. Again, it says seek, not get. You're not entitled to get a second opinion, but you are entitled to seek one. However, and this is a really critical point, you do not have a right to a referral, typically from your family physician to a specialist. Why? Well, because, and I'm going to use a bit of a silly example here, you do not have the right to go into your family doctor's office and say, "I have a headache, I demand a referral to a neurologist." You don't have a right to do that. You can try, but your family physician is going to say no. And she's not required to say yes. You do not have a right to do that. However, you are entitled to say, I have a headache, I would like follow-up tests, or I would like something done. And if your family physician either refuses or is not interested, to seek a second opinion regarding your headaches or whatever diagnosis that you may or may not have at that point. So I really want to kind of emphasize again this distinction between what you do have a right to, which is to seek a second opinion, but you do not have a right in our healthcare system in Canada to demand that you be referred to somebody. Okay. So moving on from here to the next slide. This is the three-step process that we share with all of the individuals and organizations that we work with to help them create an actual advocacy plan that you can then implement in support of your personal goals or your broadly based issues. So this is a plan for you as a patient, for you as a caregiver, to interact with people who are providing you care. This is very practical. We're finished with the theory of advocacy and doesn't require substantial resources, but it does require three things that I think are important to acknowledge. Number one, it takes time, which is really unfair because some people who get sick don't have a lot of time, but that is the unfortunate reality of advocacy in most cases. It takes a commitment. This is a conversation that you have with yourself or others in which you commit to not give up on your goals until they're reached. And finally, it takes a willingness to both start and stick with it. But in healthcare, with the express ability to take a break when you need it as both patient and caregiver. So yes, you have to start. Yes, you have to stick with it. But sometimes, and Roxanne noted this in what she had to say, sometimes you need others to speak for you. Sometimes you can't go out on a given day, a given week, a given month, and continue to do this work, no matter how committed you are to it, because you can't. And that's fine. That's okay. That doesn't negate your commitment to advocacy, and it doesn't in any way impact what it is that you're trying to achieve. It's critical that we acknowledge that healthcare and advocacy must be designed as such so people can take the time away from it when they need to. Okay, next slide. So what do we mean by key message development? Essentially, for every issue that you want to talk to your healthcare decision maker or provider about, you need to be able to explain that issue in what we call 3 key messages totaling up to 75 words. We call this conveying the core elements of what the person you are advocating to needs to know in a compact manner. Conveying the core elements in a compact manner to the person you're advocating to. Now, why do we need to do this? Why am I suggesting this to you? Well, like a good personal story, it keeps you focused on the issue at hand, ultimately to the benefit of both you and your healthcare provider. Imagine how happy every clinician would be in their job if everyone they interacted with quickly and efficiently got to the point. And that's what key messages force you to do. It sets the stage for a dialogue with your healthcare provider, including asking questions and ensuring the free flow of information, as Roxanne mentioned. It prompts you to do your research and to be well informed, potentially knowing as much as your physicians, as Peter talked about. It can help to remind you to write everything down that you're told and that happens to you, to keep track, as Roxanne said. It also sends a very subtle message to anybody you're advocating to, including a healthcare provider. You know what you're doing, and you will not be satisfied with suboptimal solutions. So if we go to the next slide, here's a model that we use when we work with people and organizations to develop key messages for use in their advocacy work. It's just a model, it's not the model, but we think it's one that in most cases can be helpful for people who are trying to do this work. So your first key message. In most cases, your first key message should describe the problem, the issue, the challenge. Why are we here? What are we going to talk about today? What do you want to talk about to your healthcare provider today? Secondly, what is the impact of the problem? How is this challenge, this concern impacting me as your patient? And then finally, what would it look like if we solved or didn't solve the problem? We try to be positive. We try to talk about what would it look like if we solved the problem. But ideally, what you want to do is paint a bit of a picture of how you're hoping if your problem were to be solved, or if your issue were to be resolved, let's say side effects from a medication, what would it look like? How would it be better for you, kind of thing? And remember that you don't have to develop these key messages alone. Paula talked about the importance of using resources like LLSC, programs at hospitals and clinics, and support groups. Next, we're going to look at your advocacy tools. And it's the second step in your plan development. They are the means of delivering your 3 key messages. Anything that you have or can create that may be used to communicate with people is a potential tool. So when advocating for yourself or a loved one in healthcare, some typical tools would include in-person or virtual appointments or meetings, emails or texts, phone calls, of course, handwritten letters, photographs, even potentially social media. The list isn't as long as when you're advocating to government, for example, but you may think of some other ideas for tools that I haven't mentioned. I just gave you a few sort of off the top. You see on the screen there the words educate, demonstrate, advocate. I just want to pause here for a second to kind of emphasize a little bit about the process again. If you're going to advocate to anybody about anything, it doesn't matter what it is or what the circumstances are, the first thing you need to do is to educate them about your issue. And you do that by delivering your key messages we just talked about. Then you have to demonstrate to them why your issue is important, not to you, but to them. So ideally, you're trying to demonstrate, hey, it's beneficial to you as well as to me if you can give me what I need. And then that's the last piece, the advocate, which is essentially your ask. So we talk about educate, demonstrate, advocate. 3 steps, you can't do them out of order, you can't miss a step. That's essentially it. And then the next slide, your ask, which I mentioned back when we were talking about your personal story, but I want to refine it here a little bit. Typically, when I give versions of this presentation to government, we emphasize asking for the one thing you need and not a list of what you want. Particularly, again, if you're advocating to government, if you ask for everything, you'll get nothing. But we're not talking about that kind of advocacy today. We're talking about personal advocacy as a patient or a caregiver in healthcare. And so in that regard, we say, you're going to ask for the most important things you need at the moment, not a list of what you want. I'll say that again. You're going to ask for the most important things that you need at the moment. You may need more than one thing, but not a list of what you want. One more thing that's very important, what you ask for must be tangible. It's got to be a thing. It's not things like, I need your help, I need your support, I need your commitment. Those aren't asks because they're not tangible. Come to your decision maker or your provider with a very practical, actionable solution that you would like them to do for you or the person you're caring for, to the extent, of course, that you can determine what that might be. Sometimes you might not know, but if you do know or you can know, bring that to the table. And just as a summary slide next, let me draw your attention to the last bullet on this slide. Never give up. It's easy to say, but it's tough to do. it's really tough to do for a lot of people who are advocating as patients and caregivers, especially when you're sick or you're caring for someone who isn't well. This advocacy stuff can be really hard to keep doing day after day. But let me leave you with what Roxanne had to say at the conclusion of her video that really stuck with me in advocating for yourself or a loved one. And that's the next slide. Speaking up, asking questions, keeping track. These are so important. And so is having hope. So let's move to just the Q&A slide. I'll come back up on screen. And now, Charlotte, I believe we're going to answer some questions that were gathered prior to the session today.
Yeah, absolutely. So we did have some people that submitted questions in advance, so we're going to start with those. If you have questions, feel free to use the Q&A box on your Zoom panel, and we will get to as many as we can after addressing the first couple questions. All right, so someone asked, how can I go about advocating for access to treatment that isn't available in my home province?
Okay, very good question. So let's start with the difference between a treatment being available versus being accessible, because the question was about availability. In the case of medications, once a drug is approved by Health Canada, it is available. It's technically available. You can buy it if you have the money in most cases, but it's not accessible for most people, meaning that if you don't have the money or you don't have private drug coverage, for example, the only way to get it is through one of the 19 public drug plans in Canada. So the best way to get access to any treatment that is not accessible or funded in your province always starts with meeting with your provincial elected representative. So MLA, a member of the Legislative Assembly in some provinces, MPP, member of provincial parliament in Ontario, MNA, member of the National Assembly in Quebec, and then in Newfoundland and Labrador, member of the House of Assembly. And ask them to write a letter on your behalf to the Minister of Health, asking if or when you can expect this treatment to be publicly funded. Now, after that, it gets complicated. Depending on the kind of treatment, if it's delivered in a hospital or a clinic, or if it's on an outpatient basis, or if it's already approved for other indications, it can get quite complicated. But as a starting point, generally speaking, as an individual, start with your provincially elected representative for something that's not accessible. Okay.
Awesome. Thanks so much for addressing that. So we had also received a question. How can I go about advocating for a rare type of blood cancer, possibly one that doesn't have a lot of research or a lot of specialists attached to it?
So the short answer is, and Peter touched on this, it's by becoming a specialist yourself. I had the privilege of working with a patient group. It was a brand new patient group in a solid tumor area. And after, I guess, it was probably about 3 or 4 years, I'd been to a number of sessions with them, medical sessions. So where they would invite patients and caregivers to come to a hospital and to listen to clinicians and learn more about treatments and research and that kind of thing. And by about the 3rd or 4th year, every clinician who walked into the room said to the 2 founders of this patient group, I'm going to tell everybody right now, these 2 know more than I do. They weren't physicians. They had no clinical training, but they had immersed themselves as people into learning and understanding what it meant to have this kind of cancer. So really becoming a specialist for your own purposes, I think is very important. You want to build relationships with all of the clinician treaters you can find. You want to work with organizations like LLSC to get your blood cancer on the association's agenda, for example, or build your own network of like-minded people if it's not already on somebody's agenda. Host an information session with patients, caregivers, families, patient advocacy groups, physicians, researchers. Get trained as an advocate. like a little bit about, I've given you an introduction today, but further training to become an advocate and build that advocacy plan that I touched on. Get on social media, highlight personal stories, as we talked about, and then, of course, build relationships, as I mentioned as well. So those are some ideas.
Thank you so much, Ryan. Someone also asked, do you have any suggestions for advocating for yourself or a loved one when you don't have a family doctor to support you?
Sure. So the answer depends on what you're advocating for. So if you're advocating to government, you don't need your family physician at all. In other words, if your target is government, you don't need to have a family physician to be able to, in theory, do that work, or even in reality, I think. To a specialist or to a hospital, if that's who you're advocating to, it would help if your family doctor was supportive. I think we all sort of understand that, but it's not a requirement, not a requirement. But if your family physician is being obstructionist, then that's a whole other story. As difficult as it may be, you may need to find another family physician. That's very hard to do, I know. But if they are getting in the way of the care that you think you need, and I would like to hope this happens very seldom, then you may need to go somewhere else. Irrespective of whether your family physician is supportive or not, the principles and the steps to effective advocacy that I just went through with you remain exactly the same.
Okay, thank you. We also have a question. How can I handle a specialist who dismisses my side effects that impact my quality of life? They say that these side effects are just sort of the normal part of this treatment.
Yeah, I really like this question. I think it's very important because it touches on a few different things. So I guess my first piece of advice is to start by being very direct. And I thought a lot about this question. I've written out some text here that I think would be sort of effective, something along these lines, to say to this person. It's my feeling that you have been dismissive of my side effects and the impact that they are having on my quality of life. Is that your perspective? So make a statement and then ask a question. Is that your perspective? Now, the person will probably say, no, I haven't been dismissive. Then you can reiterate that that's how you've felt. Remember, you can't rationally argue with somebody's feelings. When somebody says, I feel this way, you can't, or you certainly shouldn't, argue with them because it's the way somebody feels. These kinds of things, though, you must remember are inherently subjective. I always remember back to the time I did a session where in psoriasis, and a dermatologist was presenting, and he said something like this. And by the way, when you have severe psoriasis, it can be debilitating. It can be very threatening to your life. He said, sometimes somebody will come in and they'll have psoriasis covering a huge portion of their body. And they'll say, it's no big deal. It's fine. And as a physician, I need to say, that's not fine. You're really sick and we need to get you treated and we need to get you better because having psoriasis covering 60% of your body is threatening your life. Other people come in and they have psoriasis the size of a dime on their hand and the world's ending. They are panicked and they can't believe the impact that this is having on them. The job of a good clinician is not to be dismissive of either one of them, but it's to try to help to put in perspective what it is that they're dealing with. And when they need a certain kind of care, to suggest that they get it. And when something perhaps isn't factually or clinically as threatening as they believe it to be, to talk to them about it, to listen to them about it, to try to understand why they feel so threatened by something that, again, clinically isn't necessarily all that threatening. So this exchange alone that I sort of led with in this question may be enough to get you on the same page moving forward. And again, if you can't communicate with somebody in a direct manner, you either may need to find another healthcare provider, or another option is bring in somebody who can. Not all of us communicate the same way. Not all of us can be as direct as other people. And sometimes in advocacy, or a moment in advocacy, really requires a very direct and frank conversation. If that's not you, that's fine. Go find somebody who is comfortable doing that and bring them in. And finally, just Charlotte, on this question, share your personal story of the impact and research a potential solution to demonstrate that you want to solve this problem that the issue is having on you, the impact, and not just be seen to be, in the eyes of the person who's caring for you, complaining. In other words, try to bring a solution to the table to the extent that you can, and they'll likely be more responsive.
Thanks so much, Ryan. That's a really good insight. We had a couple questions come in through your presentation, so we'll probably just take a couple more minutes to address those. So someone asked, I find that with the referral, the specialist receiving the referral may not get all the information. I don't want to waste the specialist's time, but I want to make sure that they receive, what they need to receive with that information. So any suggestions about, I guess, that disconnect when you're getting referred to a couple different people?
Mm-hmm. So it touches on a couple of things. Number one, you are, as you all know, I trust, entitled to your medical records. They are your records. You are entitled to them. You can get them. But aside from that more sort of technical point, I guess the one thing I would suggest is ask the specialist, is there anything that you think is missing? And if there is, can I go away and try to fill in some of those gaps and send you that information? In other words, don't say, let's sit in this room for 3/4 of an hour and I'll tell you everything I think you need to know. They don't have 3/4 of an hour, but you can go away and get the information and then send it to them. So getting clarity on what it is that they may be missing. Now, they may not know what they're missing. That's also a possibility. You don't know what you don't know. So one of the other things I know that we suggest to people when we do this work is come in with your own little one-pager, no more than a page, one-pager of essentially your clinical summary. I realize it could be a lot longer, that it might be very complicated, but like your key messages, try to distill it down maybe to just the essence of what they need to know, hand it to them, and just say, this is the top line. Is there anything in here that you didn't know, or is there anything in here that you think might be missing? Because if there is, I'll go away and find it and bring it back to you, kind of thing. So those are a couple of suggestions that, again, we've used in the past when working with people around personal health care.
That's great. Thank you. So it looks like we have 2 more questions. So the first one is, my doctor said in his notes that he would like to see me every 6 months. But it's been about 2 years since I've had an appointment with him.
Right.
They do get their blood work done regularly. They're following all of that. Should he push to have an appointment, or should he just wait, for the physician to follow up? I guess we see this quite a bit in pandemic. It's harder to get an appointment. How
Sure.
much should you push back to get regular visits, or is that something that you should wait for your sort of physician to bring up?
So the short answer is don't wait, kind of thing. If you know that your clinician has noted that you are to be seen twice a year or whatever it may be, then I would suggest it's your responsibility to make sure that you get in there twice a year. Now, if on one of those visits your physician says, I don't think I need to see you twice a year anymore, I think I only need to see you every 18 months, and you're comfortable with that, then I think you can go to 18 months. If you think you should still be seen every 6 months, then you're going to need to make the case. You're going to need to explain to that physician why it is that you think you should still need to come in when they're saying, I don't think I need to see you as frequently. So I think it's always okay to push within reason. This is your care. This is you or your loved one. So I don't have any problems with that. I would never suggest you just wait. That's just not a solution. Now, last thing I'll say is this is not within the context of a pandemic. I'm giving you this advice or this suggestion. Obviously, being in a pandemic changes literally everything for many, and unfortunately, has changed for many patients the care that they've received. But outside of the context of something like a pandemic, you're okay to push.
Awesome. And then last question. So if you find that your care isn't what it needs to be, or if you feel like you haven't been treated properly by your healthcare team, what are some of your options?
So it really depends on. So I would describe it as sort of a. How can I say this? You can kind of go up in levels, if you will, of engagement. So let's go to the extreme, or an extreme, not the only extreme. An extreme would be that you believe that you have received, let's assume it's a physician, for example. It could be any healthcare professional. We have 21 regulated healthcare professions in Ontario. The other provinces are similar as well. You could go to the body that regulates that healthcare professional if you feel that you have received poor care, poor quality care. They haven't fulfilled their responsibilities as a licensed health practitioner in the province in which you live, and you could lodge what is essentially called a complaint. All colleges of regulated health professions have a complaint process, so you can do that. But again, I'm going to suggest to you that is a bit of an extreme, not because it wouldn't be warranted in most cases. That depends on the circumstances, but their only ability is to discipline that provider. They're not going to get you better care. They're not going to help you. They're not there to help you. They're there to discipline their members, the healthcare providers. So it doesn't. Well, it's a solution. It doesn't really help you with better patient care. So if we come back down to something that can kind of help you, I think it's really about trying to potentially find somebody else who can provide you with that care, to ask around, to make connections with organizations like LLSC and share your story, and just say, hey, look, I don't think I've been getting good care, but I'm not exactly sure. I don't really know. Can I share my story with you? And can you give me some feedback? And can you let me know? Are there other people who have been through this? There's lots of Facebook pages and things like that out there around people who are connected because of all kinds of different things, including the care that they have received. And as long as you can kind of keep everything in perspective, meaning that you want to make sure that what you're feeling is one thing, but that your feeling isn't disconnected to the, what I'll call, objective reality of what happened to you. So again, I never dismiss people's feelings, but sometimes the way you feel isn't exactly necessarily a reflection of what happened to you. But if it is, then I think, again, talking to people who are in similar circumstances, understanding what could be done. But at the end of the day, you're going to have to seek out other care. It's not easy, but you're going to have to seek out another provider if fundamentally you don't believe you're getting proper care from the person who is supposed to be providing it.
Thank you so much. That's a really, really good insight. So I think we'll end it there. Can we bring up the slideshow again? Perfect. And so we would like to thank our sponsors for today's event. Next slide. So please remember that we are here to help. You can reach us by email, by visiting our website, bloodcancers.ca, or by giving us a call toll free. Note that a short survey will be sent to all of you after this presentation. If you can, we'd love for you to take a moment to fill it out. It really helps us plan these education events. And with that, I just want to thank you all for being with us here today. Thank you again, Ryan, for a fantastic presentation, and I hope everyone has a great rest of your day.